Hi, let's talk about the principal groups of lymph nodes, trunks, and ducts. In this video, we'll discuss the return of lymph from the major regions and distributions of lymph nodes, including the head and neck, the thorax, the breast and axilla, the upper limb, the abdominal pelvic region, and the lower limb. So the lymphatic system begins in lymphatic capillaries, which are typically embedded within capillary beds of the cardiovascular system. These lymphatic capillary beds absorb excess filtrate and unidirectionally coalesce into lymphatic vessels. These lymphatic vessels are from time to time punctuated by lymph nodes. These lymph nodes are sites of immune responses. These are also sites that can predict a pattern of metastasis of malignancy through the body. The lymphatic vessels flow into lymphatic trunks. These trunks are regionally named, sometimes for where they're located, for instance, lumbar trunks in the lumbar region, or sometimes they're named for the vessel that they mirror. So a jugular trunk associated with the internal jugular vein, or a subclavian trunk associated with the subclavian vein. These trunks are going to feed into lymphatic ducts, of which there are two. Draining into the right venous angle, we have the right lymphatic duct, and draining into the left venous angle, we have the thoracic duct. Now, as you can see on this fellow to the right, the pattern of lymphatic drainage of major groups is rather asymmetrical with respect to the body. So everything here in blue, so the right head and neck, the right upper limb, and the right thorax drain into the right lymphatic duct. Everything else, so the left head and neck, the left upper limb, the left side of the thorax, the abdominal pelvic region, as well as the lower limbs, are all going to drain into the thoracic duct. So let's take a look at some of these major or principal groups that pertain to the body, those being the head and neck, the thorax, the upper limb and axilla, the abdomen and pelvis, and that will be inclusive of the viscera, as well as the lower limb. So let's take a look at what's going on in the root of the neck with the various ducts. So as I've already said, there are two major ducts. There is a right lymphatic duct draining into the right venous angle. The venous angle, as you may recall, is the union of the subclavian vein with the internal jugular vein. So that is the right venous angle. Here is the left venous angle. So there is the right lymphatic duct draining into the right. Here is the thoracic duct draining into the left. Now, draining into these ducts very adjacent to the venous angles, and sometimes even draining into the vicinity of the venous angles independently of these ducts, are three major trunks. These include the jugular trunk, the subclavian trunk, and the bronchomediastinal trunk. These trunks are bilaterally paired, so we have both right and left series of these trunks. And so on the right side here we can see the jugular trunk descending with IJ. We can see the subclavian trunk coming over with the subclavian vein. And we can see the bronchomediastinal trunk ascending through the mediastinal space posterior to the superior vena cava here, going behind the right brachiocephalic vein and eventually coalescing with the other trunks at that right venous angle. On the left side, we see something a little more special. So the story of the thoracic duct actually begins inferior to the diaphragm as the cisterna chyli. The cisterna chyli is going to receive lymph from the abdominal pelvic region as well as the lower limbs. So it is a clearinghouse for lymph below the diaphragm. That cisterna chyli is the proximal dilation of the thoracic duct, and it's going to begin right laterally, and it is going to travel through the diaphragm and ascend on the right side of the mediastinum. And then it is going to cross over from right to left at about the level of the sternal angle. And that thoracic duct will continue on and wrap around the subclavian artery and vein and insert into the left venous angle. So we can see that there is quite a large pathway. If you're exploring this region cadaverically and you're looking at the posterior mediastinum, the thoracic duct is going to take on a very veiny appearance. So let's take a look at some of the principal groups of lymphatic tissues and nodes in the head and the neck. So surrounding regions of the naso and oropharynx, we have Waldeyer's ring. Waldeyer's ring consists of organized mucosal associated lymphoid tissues or lymphatic nodules that are embedded in regions of the naso and oropharynx. So for instance, there's the nasopharyngeal nodule, aka the adenoid. There are the tubal tonsils. There are the palatine tonsils and also the lingual tonsil. So that's going to make a nice ring about the aerodigestive pathway. So coming into contact with the mucosa will be everything that is either breathed in or consumed. This lymph is going to drain into the superior deep cervical nodes, specifically one called the jugulodigastric node. Now, the deep cervical nodes are going to be in association here with IJV. And they form two distinct groups. There's a superior group and an inferior group. And we can divide the two by their relationship to the tendon, the intermediate tendon of the omohyoid muscle. So superior is superior to the tendon, inferior is inferior to the tendon. And so here we can see that jugulodigastric node. And so all of those pharyngeal malt tissues are going to drain there. So the jugulodigastric node is going to become inflamed generally whenever there is an immune response mounting. And so from Waldeyer's ring, which is a common place to mount an immune response. So usually if there's any sort of exudative pharyngitis, so that would be a sore throat with exudate, as well as an inflamed jugulodigastric node, that's going to open the door for the possibility of some streptococcal infection or strep throat. So those superior groups are going to then follow the jugular trunks into the inferior groups, and the inferior groups are going to follow that jugular trunk into one of the ducts. On the right side, it'll be the right lymphatic duct. On the left side, it will be the thoracic duct, or they can go into that vicinity independently. Now, within this group of lymph nodes are supraclavicular nodes. And it's probably important to keep in mind everything that is traveling through this region, not just the jugular trunk. So, keep in mind, let me change colors here for a second. So we do have the jugular trunk descending down. We also have the subclavian trunk coming over. But in addition to that, we have the bronchomediastinal trunk ascending, and on the left side, we would have the thoracic duct coming over. So these supraclavicular, if we think about what that means, supra means above the clavicles. If you palpate the region above your clavicles, so if you feel that region, those are the supraclavicular fossae. And a lymph node that hypertrophies there, or if you have a little bit of lymphadenopathy there, that can be indicative of a very serious disease. So specifically on the right side, that can be indicative of a malignancy from the thorax, and on the left side, we say that this is Virchow's node. This can be indicative of a malignancy from the abdominal pelvic cavity or the thorax, because abdominal pelvic cavity by means of the thoracic duct, or the thorax by means of the bronchomediastinal trunk. And so having a lymphadenopathy in this region is going to be cause for immediate concern. And if you palpate anything in this region, lymph node-wise, you should probably see a physician right away. Now, as we descend down into the thorax, we see that there are both opportunities for the return of lymph from the thoracic viscera as well as from the thoracic wall. And let's take a look at the return of lymph from the lungs. So lymphatics are going to mirror the bronchial tree and pulmonary vessels. Lymphatics don't make it to the level of the alveoli. They generally start at the level of the bronchioles, and throughout this region, one can find various pulmonary nodes. So these pulmonary nodes are throughout the parenchyma of the lungs. And any sort of progression of disease, so metastasis that begins in a pulmonary node, so this would be the origin of that as 0, is then going to move to the bronchopulmonary nodes, also known as the hilar nodes, because they can be found in the hyla of the lungs. From there, lymph is going to move to the tracheobronchial nodes. So the tracheobronchial nodes exist at the bifurcation of the bronchi. There is an inferior group below the bifurcation, and there is a superior group above the bifurcation. These hilar nodes may flow into either the superior or the inferior groups. From the inferior group, we move to the superior groups. And then the superior groups are going to track along the bronchomediastinal trunks. And those bronchomediastinal trunks will ascend and have the opportunity of feeding into the lymphatic ducts, either the right lymphatic duct or the thoracic duct at the venous angles. So we can see these definite pathways from pulmonary to bronchopulmonary to the tracheobronchial, both inferior and superior, to the bronchomediastinal trunks to the ducts. So one might be able to figure out the next lymph node to assay for a metastasis, given this knowledge of the flow of lymph. We can also trace a similar pattern on the surface of the thorax. So let's say that there was a malignancy that begins in the breast. So something gets picked up in the subareolar lymphatic plexus. That would be the lymph that is within the breast itself, just deep to the areola. This lymph can move one of two directions. Now, the lion's share of the lymph is going to move laterally. So about 3/4 of it is going to be picked up by the pectoral nodes. The pectoral nodes are of a specialized group or cluster of lymph nodes called the axillary nodes. So here we can see the pectoral lymph nodes. These are in association with pectoralis major, in between pec major and pec minor in some parts. And from these pectoral lymph nodes, lymph is going to travel to the central lymph nodes. The central lymph nodes are going to be along the axillary vein. And then from there, lymph will travel to the apical lymph nodes. They're named the apical lymph nodes because they're at the apex of the axilla. So all of the axillary lymph nodes feed into these apical lymph nodes. From there, lymph is going to travel along the subclavian trunk, and then from the subclavian trunk, it will feed into either the right lymphatic duct, as shown here, or into the thoracic duct. But that's not the end of the story, so that's accounting for about 3/4 or 75% of the lymph. About 25% of the lymph is going to flow medially, at least at first, and it can either be picked up by peristernal nodes and travel along the bronchomediastinal trunk, or it can also travel to the contralateral breast. So 3/4 to the axillary group, 1/4 to the peristernal nodes, as well as the contralateral breast. Let's take a look at the lymph flow of the upper limbs. Let's remember that the major veins of the upper limbs are superficial, and that the deep veins of the upper limb are venae comitantes, or accompanying veins of major arteries. So the deep lymphatics follow arteries, the superficial lymphatics follow the veins. So the deep lymphatics are going to eventually coalesce up in the humeral nodes. The humeral nodes are of the axillary group. So this is still within the upper limb. The humeral nodes are associated with the arm. But these will flow into the axillary group, and that's going to be up around the deltopectoral triangle, or that space between the deltoid muscle and pectoralis major, where one can access the axillary vein. And from there, lymph will flow into the apical nodes. And we know that once in the apical nodes, it's a short trip to the subclavian trunk and then into one of the two lymphatic ducts. The superficial lymph, as shown here, we can see, recall there's both a cephalic vein that is lateral and a basilic vein, which is medial. We can see some of the supratrochlear nodes, some of the lateral lymph nodes on the way up toward the axilla. Now let's take a look at the abdominal pelvic cavity. So some things to keep in mind. Everything ultimately is going to be flowing into the cisterna chyli. And let me change colors here to green. The major clearinghouses of the abdominal pelvic cavity are the lumbar trunks. So the lumbar trunks are going to be running alongside the aorta and inferior vena cava and are going to flow up and eventually feed into that cisterna chyli. Now, associated with these lumbar trunks are lateral aortic nodes, also known as para-aortic nodes. So any lymph nodes along the lumbar trunks are lateral aortic nodes. The abdominal aorta gives rise to various large visceral trunks and arteries, and it's these trunks and arteries that are going to also supply the routes for lymphatics to come back to the lumbar trunks via associated vessels. So for instance, along the foregut, there are celiac nodes that are going to feed into these lymphatic trunks. There are, associated with the kidneys and suprarenal glands, renal nodes that are going to travel along vessels adjacent to renal arteries to feed back into the lumbar trunks. There are superior mesenteric nodes that come back along the SMA to the lumbar trunk. There are inferior mesenteric nodes that come back along the IMA to those lumbar trunks. So all of the viscera from the gastrointestinal tract ultimately flows back into these lumbar trunks. So the lumbar trunks are going to arise from iliac trunks and nodes. So just as the common iliac arteries are the bifurcation of the abdominal aorta at about L1, we also have these common iliac nodes along this pathway that send lymph up through these lumbar trunks. And these common iliac nodes are going to receive lymph from two major locations. So there are external iliac nodes associated with the external iliac artery. And then there are internal iliac nodes associated with the internal iliac artery. So the external iliac nodes are going to carry lymph from the lower limb as well as the wall of the abdominal pelvic cavity. The internal iliac nodes are going to drain the pelvic viscera. So again, if you know your pattern of bifurcation of the arteries, you should have a very clear picture of what's going on with the nodes. So external and internal iliac arteries comprise the common iliac artery. Same with the nodes. The common iliac arteries come together to form the abdominal aorta, which is flanked by the lumbar trunks and lateral aortic nodes. And then all of the visceral regions are serviced by their associatedly named nodes. And all of this flows up into the cisterna chyli, which is the proximal dilation of the thoracic duct, which then is going to drain into the left venous angle. Easy as can be. So now let's take a look at what is going on superficially. So let's go back to red now. To have a clear picture of what's going on, let's take a landmark into account, and that landmark is going to be the umbilicus, or the belly button. So let's take a line, an imaginary line, and draw it across the trunk there, and that's the transumbilical plane. That transumbilical plane is going to be key for the return of lymph from the abdominal wall. So anything superior to this transumbilical plane is ultimately going to drain into the axillary group of lymph nodes. Anything inferior from this transumbilical plane are going to drain into a group of lymph nodes at the lower limb called the superficial inguinal nodes. Those superficial inguinal nodes will then drain deep through the femoral triangle. So they lie superficial to the femoral triangle, hence superficial. They drain into the deep inguinal nodes, and it's the deep inguinal nodes that then feed into the external iliac nodes. So anything from the body wall takes the long way down through the lower limb before ultimately ascending through the lumbar trunks. Now let's look at the lower limb. So superficial lymph is going to travel along veins. So anything superficial follows the superficial veins. Keeping in mind we have the great saphenous vein draining the medial aspect of the lower limb up into the femoral triangle. So that lymph will follow the great saphenous vein up into the superficial inguinal nodes. And you know that those superficial inguinal nodes will then drain deep through the femoral triangle to the deep inguinal nodes, and then those will ultimately drain into the external iliac nodes, and then into the common iliac nodes, and then through the lumbar trunks. Now, some of that superficial lymph, in particular from the small saphenous or the lesser saphenous, that's going to dive deep into the popliteal fossa, into the popliteal vein. And so we'll have lymph from the deep lower limbs following both deep arteries and veins. And ultimately, that is ascending into those deep inguinal nodes. So from the deep again to the external, and so on and so forth. So there is a very distinct pattern of lymphatic drainage here. And that leads us to our assessment question for the video, and that is superficial infections of the lower abdomen below the umbilicus and lower limb tend to be picked up by which group of lymph nodes? Is it A, axillary, B, lateral aortic, C, hilar, D, para-aortic, or E, superficial inguinal? Well, it doesn't make sense that anything above the transumbilical plane would be picked up by the axillary nodes, or I should say below, because axillary nodes will pick up above the transumbilical plane. Lateral aortic and para-aortic are equivalent. Those are following the lumbar trunk, so eventually they'll go through those lateral aortic groups, but not right away. Hilar nodes are in association with the hyla of the lungs, and so the correct answer is E, superficial inguinal nodes. We then know that they'll go to the deep inguinal nodes, then to the common iliac, then, external iliac to common iliac to lumbar trunk, and through those para-aortic nodes up to the cisterna chyli. Thank you very much for your time.